Okay, so good morning again. This week's lecture is going to be an infective endocarditis. What we're going to do, we're going to talk about the definition. What is infective endocarditis? Signs and symptoms that the patient will present with, the, the cause, how to diagnose it, the echo features, and the complications of endocarditis. All right, so how do we define infective endocarditis? So it's an infection of the endocardium, usually the valves, and the infection will be in a setting of you need some abnormality in the heart tissue for the infection to start and develop. So if you have normal structures in the heart, it's very unlikely for you to get infective endocarditis. You need some type of abnormality. And patients with congenital heart disease are more likely to develop infective endocarditis. So what we're talking about is if you have a septal defect, ventricular septal defect, ostium primum defect, other complex congenital disease, because the flow pattern in the heart is going to be abnormal, and that will, if an infective organism goes to the heart, then you get a nidus of infection which can grow. So usually with abnormal cardiac structures, so you'll find that patients with a prosthetic valve. So if you have a foreign material inside the heart, prosthetic valve, whether it's bioprosthesis or mechanical prosthesis, those individuals are more likely to develop infective endocarditis. We have the drug abusers who sometimes they'll get infective endocarditis with the so-called normal heart structures. And one of the reasons for that is intravenous drug abusers, when they inject infected material in the venous system, they sort of overwhelm the system because they inject so many organisms. It overwhelms the system. And not only that, some of those individuals will be immunocompromised. That is, their system cannot fight infection appropriately. So they will and they can develop infective endocarditis. So as mentioned before, you need some background to form these infectious nidus. So there's a high incidence in patients with damage or disease valves, such as rheumatic. So someone have rheumatic mitral stenosis, mitral regurgitation, aortic stenosis or regurgitation, mitral valve prolapse, bicuspid aortic valve, and we had mentioned prosthetic heart valve. So these are individuals more likely to develop the infection. And again, patients with congenital heart disease, intravenous drug abuse is a large group, and because they inject in the venous system, you'll commonly find the vegetation, the infected material on the right-sided heart valves, such as the tricuspid and the pulmonic to a lesser extent. Pacemaker lead is a foreign material inside the heart, and you can have infection on the pacemaker lead itself. And if there's any lines going inside the heart, we commonly put central lines either to give fluid or to give medications. And these lines, central line resides either in the superior vena cava or in the right atrium. So you can have infection of these lines. Okay. What are the signs and symptoms of infective endocarditis? It's an infectious process, so a lot of patients going to present with, classic infection signs and symptoms: fever, malaise, fatigue. The important thing, though, because you commonly have the infection on the heart valve, it's going, when you listen to the heart, you're going to get an appropriate murmur. That is, if the vegetation is on the mitral valve, the the infectious material is going to prevent normal functioning of the mitral valve. So you're going to have evidence of mitral regurgitation because it's going to prevent proper closure of the valve. Similarly, if it's on the aortic valve, you'll hear most likely aortic insufficiency, and the tricuspid valve, and the pulmonary valve to some extent as well. So we talk about a new murmur or a change in murmur, and it's just the mechanical situation that exists. So if the patient did have, say, a mitral murmur before, okay, the patient had a mitral murmur before, once the vegetation gets on the mitral valve, it's going to change that murmur, the nature of the murmur. So when you listen to the murmur, it's going to be different. So we talk about a new or a change in heart murmur. A lot of these individuals have a subacute or a chronic process. So they will lose weight. We'll talk about cachexia. So there will be cachectic, obviously weight loss, malaise. I will mention fatigue. Night sweats is also a feature of infective endocarditis, and you can get what we call septic embolism. That is, a piece of the infected material can break off and travel through the arterial system and lodge in very small blood vessels, causing what we call ischemia and infarction. So the tissue that the blood vessel normally supply will become ischemic, a lack of blood flow, and if the obstruction is complete, then that tissue can die, infarction. So you can get CVA, cardiovascular accident, which is a stroke, okay, because the infected material can travel to the brain, or it can travel to the upper extremity, the hands, the feet, and you can get what we call gangrene. It can also travel to the bowel, the blood vessel supply and the bowel, and you can get gangrenous bowel, which is a real serious complication, life-threatening complication. We talk about Janeway lesions. These are painless hemorrhagic lesions on the palms and soles, and these lesions are infectious. So if you shake hands or you manipulate someone with these lesions, they can transfer the infection to you. Conjunctival hemorrhage is another feature of infective endocarditis. We talk about splinter hemorrhages, that you can see these in the nail beds, and then we talk about osseous nodes, which are painful lesions in the distal fingers, distal phalanx, the tips of the fingers, so osseous nodes, and then rot spots are on the retina. So what are some of the infectious causes? What type of organism will cause infective endocarditis? So bacteria is a very common cause, and the most common bacteria is Staphylococcus aureus. It's an organism which usually resides on the skin but it can, you have different, what we talk about, virulent, some of them are more infectious. So we talk about the virulence of the organism. So you can have very virulent Staph aureus, which readily cause infection. Then that's followed by Streptococcus viridans, which is another common organism. Then coagulase negative Staphylococcus, Pseudomonas aeruginosa. So these are some of the more common bacterial cause. Strep bovis. So usually when you have this strep bovis, it suggests that you might have some bowel malignancy. Clostridium septicum, and then the ASEC group of organisms. And then the ASEC is the acronym stands, the H is for Haemophilus, A is Actinobacillus, C is Cardiobacterium encanella, and then the K is Kingella. So there's the ASEC group of organisms. So those are the bacteria, but fungus can also cause infective endocarditis. And then the fungal causes includes Candida albicans, Histoplasma capsulatum, and Aspergillus. So these are fungal causes. The fungal vegetations tend to be much larger though. So how do we diagnose infective endocarditis? So it's very important. If you see someone with something that looks like a vegetation, you have to, make your diagnosis. And we use what you call the modified Duke criteria. So the modified Duke criteria, you're going to have what we call major criteria and minor criteria. So to make to have a definitive diagnosis of infective endocarditis, you need 2 major criteria, or 1 major and 3 minor, or 5 minor. So we have certain features that we call major criteria. So once you have that, it's a high likelihood that you're going to have infective endocarditis. And then we have what you call minor criteria. It's not as likely, but there's a possibility that you may have infective endocarditis if you have these conditions. So major criteria and minor criteria, the so-called modified Duke criteria. So for the definitive diagnosis, to make the diagnosis for sure, you need 2 major criteria, okay, or 1 major, 3 minor, or 5 minor for the definitive diagnosis. For the possible diagnosis, patient may have infective endocarditis, you need 1 major and 1 minor, okay, or 3 minor. This is just a possibility, not definite. So the major criteria includes blood cultures. So if you do blood cultures and it comes back with organisms, any of the organisms that we mentioned before, there's a great chance that, because the blood culture is telling you that the blood is infected. You have infection in the blood. So it's a good possibility that it's coming from the heart valve structure or the endocardium in the heart. But when we say blood culture, it has to be one of the typical organism, and it has to be from 2 separate blood cultures, because you can have contaminants. Remember, there are bacteria on the skin, so you can have contaminant when you take in the blood cultures. So when you do a blood culture, you take some blood from the patient and you put it in what we call a culture medium, which is usually a bottle or a tube with a broth, a solution which promotes growth of certain organism. So you can have contaminants. So it has to be at least 2 separate blood cultures. And we talk about multiple sites as well, from multiple sites. So positive blood culture is one of the major criteria. The other major criteria are echo features. Echo features is another major criteria. And the echo features we're talking about is vegetation. when you do your echo, if you see obvious vegetation, then that's a major criteria. Or you may see abscess, okay, fluid fill infected area, abscess. Or if the patient has a prosthetic valve, you may have a partial dehiscence of the prosthetic valve. That is where the valve is sewn into the heart structure. That's now broken loose, and you can see what we talk about. The valve is the prosthetic valve is rocking, and sometimes you may see it completely dislodged. So partial dehiscence of prosthetic valves. Again, we talk about new valvular regurgitation, because once you have the infected material on any of the valve, it's going to prevent proper functioning of the valve. So you can have a new murmur. So if it's an individual that you did an echo on before and they didn't have significant, say, mitral regurgitation, and they come to you now with significant mitral regurgitation, then it may be a vegetation on the valve. Um, so, so the major criteria, blood cultures, because if the patient have infection inside the heart, the blood cultures is a very, very great chance that the blood cultures, the blood itself is going to be infected. So when you take a sample of the blood and you put it in what we call a culture medium, that organism will grow, and then you can identify it readily. And then the echo features, because of the definitions and infected material in the heart. So you look inside the heart, and the most common location is on the valves. So you can see vegetation, infected material building up on the valves, or the infection may eat away the tissue, causing abscess formation. Again, a prosthetic valve is a foreign body which is placed inside the heart. So those prosthetic materials commonly get infected. So where it is attached to the heart, where you sew it, we talk about dehiscence at where you have the suture ring then. So it will break away, because that tissue is going to be soft, and you'll have dissolution of the tissue. So, all right, and then new valvular regurgitation. So the minor criteria. So the minor criteria are less specific for infective endocarditis, but when patients have a whole lot of these features, it increases the likelihood of infective endocarditis. So minor criteria, we talk about the predisposing factors such as cardiac lesions. Remember what we said. You need an underlying cardiac pathology for a majority of the patients with infective endocarditis to develop infective endocarditis. So the patient may have rheumatic fever, the patient may be immunocompromised, maybe a diabetic individual may have HIV or some other immunocompromised condition. Or the patient may be a drug abuser, intravenous drug abuser, and because they inject these drugs into the venous system, usually it's a lot of infected material that goes directly to the heart, so they overwhelm the protective system. So other minor criteria, evidence of embolism, because remember these infected material can break off and travel distally to obstruct distal blood vessels. You can get a CVA, gangrene of the limbs, the bowel, stuff like that. So if you have evidence of arterial embolization, that is also a minor criteria. Pulmonary infarcts, this infected material may travel to the blood vessel in the lungs blocking the blood vessel in the lung, so that a portion of the lung tissue may die, pulmonary infarcts. And so if you have evidence of that, then that's another feature. Conjunctival hemorrhage, remember that's one of the features. Fever greater than 38 degrees Celsius. And then we're talking about glomerulonephritis, evidence of immunological problems, Osler's node, glomerulonephritis, and then positive blood cultures if it does not meet the strict criteria of the measure. With the measure criteria, it has to be multiple blood cultures from separate sites. So if you have positive blood cultures, but it doesn't meet the strict measure criteria, then that's a minor criteria. So you see, you have multiple minor criteria. So to make the definitive diagnosis, if you have 5 of these, you can make the diagnosis. So the patient may have an underlying rheumatic valvular problem. You see, the patient may have pulmonary infarcts, temperature, Osler's nodes. Okay, so these, once they have 5 of these, makes the diagnosis. So if you have 2 of the major criteria, positive blood cultures using the strict criteria, and then echo features such as vegetation, then okay. So again, for the definitive diagnosis of infective endocarditis, you need 2 major criteria, 1 major, 3 minor, 5 minor. For possible diagnosis, 1 major, 1 minor, or 3 minor. Okay. So the skin lesions now, we're talking about the Osler node, which are immunological features. So the Osler's nodes. Okay. So this is a vegetation on the tricuspid valve, and vegetations can be large. However, when you see very large vegetation, a lot of time it's fungal, okay? Large vegetation. Especially in a patient with intravenous drug abuse, they overwhelm the immune system. Okay. And you know, on the M mode, you will see evidence of valvular problems. You know, the valve will be thickened, irregular. Let's see what we have here. So this is a patient with rheumatic. This patient has rheumatic mitral disease. So these are individuals that are, you know, more prone to develop infection of the valve. So bear that in mind. Okay. It looks like there's something on the tricuspid valve right there as well. So there's something definite on the tricuspid valve. See, it's fairly large. So you have to look for these things. So just imagine this lesion is present on the valve. So the valve is not going to close properly. So you can, you'll get, when you listen to this patient, you'll get a murmur suggestive of tricuspid regurgitation. And then when you do your echo, you will see evidence of tremendous tricuspid regurgitation. So this is a actual case of mine. This lady present with a vegetation on her mitral valve, posterior mitral valve, and well, her presentation was actually of an acute heart attack. So she presented with an acute heart attack, but the the strange thing is that she presented with infection. Her temperature was up, her white cell count was up, you know. So we did blood cultures, we did the echo. So she satisfied. She had a major criteria, two major criteria. We did a transesophageal echo, and she had vegetation in the mitral valve. I think she did have vegetation in the aortic valve as well, which probably that's the one that embolized. And she had, okay, this is a different patient. You can see that the tricuspid valve has this patient, this one, the first thing we did was, this is a transthoracic echo, which showed the vegetation and tricuspid valve. And then we went on to a transesophageal echo. And the reason for the transesophageal echo, you can see, you can identify the complications of the vegetation or infective endocarditis more readily with your transesophageal echo. You can see things like abscess, fistula. So it's not unusual for you to go on to do your transesophageal echo. Okay. So it's a T again. Okay, let's see. Tricuspid valve was involved. So the important thing, you have to identify, where, which leaflet the vegetation is on. Okay, so it looked like the aortic valve was pretty okay. The left atrial appendage was good. You can see the lesion on the tricuspid valve. So, we've shown you the organism that can cause infective endocarditis. The individuals who are more likely to develop endocarditis, and we're showing you how to make the diagnosis. So complications of infective endocarditis, you can have cardiac complications or extracardiac outside of the heart. So cardiac, basically it's an infected material, so you can have destruction of the cardiac tissue. So the valves can be destroyed, and you can have perforation of the valve. And because the infected material is on the valve, you have improper closure. So you got regurgitation, sometimes stenosis, mainly regurgitation, prostatic valve dysfunction and dehiscence, because if these infected material resides on the prostatic valve, then it can prevent proper functioning of the prostatic valve. We talk about dehiscence as well, because the suture ring, where you suture the prostatic valve to the heart tissue, that breaks down, and the prostatic valve can get dislodged. Abscess, so infective fluid fill cavity, abscess, fistula, abnormal communication between cardiac structures, aneurysm, so weakening and dilatation of a certain portion of the heart, pericardial effusion. So it's and heart failure, congestive heart failure. So these are the cardiac complications, that are, is from the heart itself, and it is usually due to tissue destruction from the infected material. And then extracardiac, outside of the heart, the infected material break off and travel elsewhere. So the patient can present with a stroke. Or embolization to the limbs or the bowels, and those areas will die. So again, if you suspect complications, you definitely want to do your transesophageal echo, because the transesophageal echo, it has higher spatial resolution than your transthoracic. Okay, so remember, when we talk about spatial resolution, we talk about axial and lateral resolution, so you can see tiny vegetation much better with your transesophageal. Okay, it has higher sensitivity and specificity than your transthoracic, and it's better than your transthoracic if you're looking at the prosthetic valve, especially if you're looking at the mitral prosthesis. So if you have high-risk patients, you definitely want to do your transesophageal echo. If you suspect complication, abscess, fistula, stuff like that. If you're looking, you didn't see anything, you suspect endocarditis, you may want to repeat the transthoracic in about 7 or 10 days. So if your suspicion is very high, say you have a drug abuser, you hear a heart murmur, and the blood cultures are positive, they look sick. You did your initial transthoracic echo. You might want to repeat it a week or two later, because they may just start forming the vegetations, and so once you give it time for the vegetation to fully develop, we can identify it. So that's